Um, Actually, I'm going to be Matt State today as well as James Leckman. So if we can move back, I was going to give Matt's lecture on genetics first. I'm not sure if that's going to happen. Let me also, thank you. Let me also say that perhaps during the discussion period or afterwards, we can talk together and perhaps with Larry Scahill about the use of habit reversal treatment. I think among the various treatment options we have for Tourette syndrome, one of the options that's emerged really over the past 20 years is something called habit reversal treatment. And it's my thought, and we're actively studying it at the moment, that there's a likelihood that what we're doing with habit reversal is allowing the patients to be more aware of the premonitory urges, the stimulus that they experience before the tics, and to help them come up with alternatives that will allow their self-regulation to be more effective. So let me tell you briefly about where we stand with the genetics of Tourette syndrome. I would also say that in our search for a cure, we must not lose sight of the individual, and the long-term treatment is to optimize the adaptation and to keep their development on track. I think it's very much in keeping with what we just heard from Kristen. And I would agree that the premonitory sensations, which interestingly, if you look at them developmentally, are not there often at the very beginning. Children begin with the motor and vocal tics, and there's usually motor tics before the vocal tics. And it's only somewhat later, often for very bright, self-reflective children, it may occur as early as 7 or 8. For most kids, it's around the age of 10 that they have an awareness of these premonitory urges. This is a quote from one of our colleagues who's a neuroscientist but also a lifelong sufferer of Tourette syndrome, a fellow by the name of Peter Hollenbeck, who currently chairs the Scientific Advisory Board. Peter was recently in Norway at a recent meeting of a European group with regard to Tourette's. And this is just a quote from him. "I finally apprehend the magnitude of the background noise that I've been experiencing for decades. The people around me do not share my tics because they do not share this, hear the drumbeat. They do not hear the sensations without sources. They do not have to have this irresistible urge to pause in mid-sentence," and so on in the endless, bewildering variety. And Matt's talk isn't really going to be addressing that. I'll be coming back to it when I talk about the potential role of aberrant neural oscillations in the last talk of today's session. We've heard today a little bit about the clinical phenotype, a fair amount about the neurobiology. We've heard Paul talk a bit about animal models. I will also be talking, in addition to the informal comments about habit reversal, about a variety of interventions. The ones that we've been focusing on recently, in addition to the behavioral interventions, have been for actually our most severe adult patients, where we've been using actually brain surgery and also transcranial magnetic stimulation. And the RTMS work actually is derived from work that was initially done in Siena with a group of Italian Tourette patients, including some adolescents. But let me move now to the genetic and epigenetic factors. We've known for a long time that Tourette syndrome has a genetic basis, at least in part, and this comes in part from the twin studies. If you have two people who are genetically identical, you would expect them to have a higher rate if there's a genetic factor than if they share on average half of their genes in common. And that's very much the case in Tourette syndrome in the twin studies that have been done. Anybody who has studied individuals with Tourette's, have worked with them clinically, knows that there's a great likelihood that there are other people in the family who are going to be affected with either this illness or some related form of the same condition. It might be a simple tic disorder, or it might be obsessive-compulsive symptoms. It's more a question of how much of a particular symptom does someone have than whether they have it or not. And initially, I think one of the reasons I went into studying Tourette's was that with some of the modeling that we were doing, there was a suggestion that an autosomal dominant disorder might actually account for what we saw in some of the large families. I must say that at this point in my career, I believe that this cannot be true, certainly not of all cases of Tourette's syndrome. We've had the techniques, we've done the studies, we haven't found the single major gene that's responsible for all of Tourette's. It's not like some other movement disorders that we were using as a model at that time. So what we've heard a lot about during the conference is and actually from the very beginning, that this single gene theory has now been replaced by what we're looking for in terms of complex genetic traits where genes that are normal genes that occur in the population somehow working together or in some additive way, probably in combination with adverse environments, are somehow contributing to the etiology of this disorder and the emergence of the symptoms. And interestingly, recent data has also sort of taken us back to single major gene etiologies. And there's a strong suggestion that this may be a valuable way of identifying some of the genes that are important in Tourette's and that in single cases may actually be etiologically the cause of Tourette's. And there's an interesting story that's emerged, and Matt State and his team, Rick Lifton at Yale and others, have really been pioneering this approach, and I think it will be promising for studies of Tourette's and possibly for other forms of disorder that occur commonly in our age population that we're interested in. And what's interesting about this is that for diseases like hypertension, hypercholesterolemia, for type 2 diabetes, it's clear that although they're complex genetic disorders where multiple genes are contributing, if you actually look for rare variants, and oftentimes this is through looking at chromosomal abnormalities in which there's been some break and rearrangement of the chromosome, you can actually pinpoint potential genes that are involved, and then when you look at those genes, you find that they may account for a very small proportion of the hypertensive cases. But if you look at the function of the gene, it begins to help you identify what the whole range of and what the neurobiology, the basic neurobiology of or the biology in the case of hypertension is actually involved in. And so this is the approach that we've been taking at Yale that's been led by Rick Lifton, Matt State, and their teams. Let me very briefly just go over the history. There are traditional linkage studies, identity by descent approaches that are quite important. There's a large effort underway led by David Pauls, who had also been at Yale, looking at affected SIB pairs, basically saying, I don't know how it's transmitted, but if both of the kids in this family have this disorder and we look across the entire genome, what sites in the genome do they share in common? And that's the place that we may actually have success in identifying the location of the gene that's involved. There's also been a lot of candidate gene studies, as well as what I was telling you before about the molecular cytogenetic studies, which I'll be coming back to. So here are some of the different areas of the genome that have been identified, and what I would point out is that there's a new site on chromosome 2, in the short arm of 2, that I'll tell you a little bit about in a minute, and then the other one I want to tell you about is here on chromosome 13. This is the location of a gene called SLIT-TRAC1 that was identified in Matt State's laboratory, published in Science, which I think for child psychiatry is a real achievement, and I'll tell you the story of Matt's finding of SLIT-TRAC1. So I'm just going to pass over these studies, actually. I hope nobody in the audience is intimately involved with them. I would say, though, that the identity by descent approach is a very powerful approach. Here you're looking for a common ancestor, and then you're looking at the transmission in subsequent generations. But if it came from a common ancestor, there's a likelihood that there's going to be a series of genetic variations that were present in that common ancestor that are going to be manifest in the populations in the subsequent generations. So we initially found 2 peaks on chromosome 4 and chromosome 8. In the replication of that study, we found actually a failure to confirm those earlier results. And just this year, we've published the results of the International Consortium, and there's a signal on 2P. I'll tell you a little bit about it. Again, this is under the leadership of David Pauls. A number of groups, including some in the UK and some in the Netherlands, have been active in this international consortium effort. Here is the entire genome. The chromosomes are listed across the bottom. I would also point out they did look at X, but they haven't looked at Y. There is an issue there that I'd like to maybe have a question about. But you can see on chromosome 2 this fairly impressive peak. Again, I think time will tell. Replication is the name of the game with regard to genetics. Let's see if it's really true. And you can see, depending on how you define the phenotype within the families, tics, OCD, you can see different peaks on this, but there's a fair consistency with regard to that particular site. So now people are looking to say, okay, what genes are underneath that peak? Let's do more extensive studies in that area. And interestingly, for a long time, some of the case control studies that were done, where you just take cases of Tourette's versus normal controls, I was not too impressed with that as a strategy. That's emerging as the most important strategy with regard to psychiatric genetics, looking for the sort of complex interaction of various genes together. Because if you have 2,000 or 3,000 people who all have the same condition and you compare them to individuals who don't have that condition, you actually have enough strength to find the signals that are necessary to identify the genes that do contribute to that phenotype. So let's talk about the rare variants, and I'll be able to give a little bit of a footnote to some of what Flora told you about, and then we'll move on to the last presentation of today. There are a number, and oftentimes, and I would actually encourage you, if you have an unusual case, what do I mean by an unusual case? One where there's absolutely no family history of Tourette's, and then it appears. Or there's some unusual part of the phenotype in terms of the child looking unusual or having some other odd combination of things. That's the kind of case that you may want to send for some sort of screening with regard to the cytogenetics, looking at the structure of the chromosomes. Because if you can find that kind of structural rearrangement, you may have a direct signal about where you should look in terms of looking for the gene that's involved. And this is the paper that's received so much attention from Science Magazine. It's from Matt State's laboratory. And I'll tell you some work that was done by Nenad Sestan, who works in our neurobiology department at Yale. And I would also say that the first author is now a medical student and was actually a pre-med student. And basically what Matt does is that as individuals come to the lab, that is to say students interested in working with him, he may give them one of the chromosomal rearrangements that have been identified, and then they work as part of the team to determine, well, what genes are involved, what potential genes are involved, and then to do the necessary screenings to see whether or not it's really important. And in this case, he gave it to Jesse, and Jesse has a first authored paper in Science Magazine. So good for Matt and good for Jesse. What did they find? They found a chromosomal inversion. Here is a case of a family where there's absolutely no other person in the family affected with Tourette's or related phenotypes, and that person had it. And when they looked at their chromosome 15, there was basically a flipping event where this part of the chromosome actually flipped around and recombined to have this odd-looking band pattern. And the way that you know that that really happened is you identify some markers, and basically if there is a split, then you would expect that marker to be divided and to be flipped, so you'd get two copies of that marker showing up in the color that was assigned to it in the analysis. And you can see here, in this particular part, you can see the two little blips, this inversion on chromosome 13, and again, with this other marker, this inversion with these two sites. So one of the chromosomes showed the flip, the other chromosome did not. So that was interesting. And actually, if you go back, you sort of, then what you do is that, well, here's some nearby genes. Which ones are we going to be interested in? And one of the ones that you'd be interested in would be one that would be expressed in the brain. So among the genes that were sort of candidates in this, The one that looked like it was going to be the most interesting was the SLT-TRAC1 gene, because it was expressed in the brain. They didn't really know very much about where it was expressed in the brain or what it did in the brain, but they knew it was expressed in the brain. So the next step in this story is that if you find a gene of interest and it's expressed in the brain, let's sequence it. Let's sequence it in hundreds of people with Tourette syndrome. Let's sequence it within thousands of people who don't have Tourette syndrome, and let's see what we find. So that's what they did. So the next interesting part of this story was that another case turned up that was also unusual in that there wasn't anybody else in the family affected. And what did they find? So here are all of the conserved elements on wild-type SLT-TRAC1. So each one of these represents a part of the genetic sequence that's conserved, so that if you look at a rat, if you look at some other member of the animal kingdom, these parts of the genome are conserved. That means that it has probably some important role to play. And what they found was what's called a missense mutation. A missense mutation means that at some point the genetic sequence was such that there was a change, and rather than having the normal sequence completely disappears after this point in time, and basically this person had one chromosome that was making the normal SLT-TRAC1 gene and another one that was making this missense mutation. I'll ask if everybody's clear about that, but there's probably not time to really clarify it. So that was interesting. And then the reason that got into science, I'm sure, is the following, is that they found, as they looked at the sequence of SLT-TRAC1, they found another rare variant. And in fact, they found the same rare variant in two different people who, if you looked at the haplotype of the area around SLT-TRAC1, could not have possibly received it by common descent. So two independent mutations causing the same mutation. And where was it? It was in a region of the 3' untranslated region. Now, I'm sure all of you know about genetics. You know about the coding regions. You know about the introns and the exons. You know about the promoter region in the front, and you know about the 3' untranslated region in the back that also has conserved regions. And interestingly, the mutation that they found was in a place where there was a microRNA binding site. So here's another piece of information that you may have missed. It turns out that in addition to genes and the proteins that they produce, mRNA and RNA is becoming a very important factor to look at as well. And microRNA is a way in which RNA can actually have an effect on the expression of genes. And this is the conserved binding site, and basically what they found was that there was an alteration in the sequence so that the binding of this particular form of microRNA, 189, didn't bind as well and didn't have the same effect in terms of altering the sequence, the expression pattern of the SLT-TRAC1. And I'm not going to go through this in detail except to say that the more you add, the more change you can see, and there's a bigger variation and a difference with regard to the mutant form of the SLT-TRAC1 versus the non-wild type, non-altered form of SLT-TRAC1. Okay, so let's try and relate this back to what Flora was talking about, and I'll just say a few things. One is that SLT-TRAC1 is expressed in the brain, in the cortex and hippocampus. You can see some areas of the globus pallidus, the striatum, the thalamus, where it's also got some expression. If you look at the mutants versus the wild type, and you do it in culture, basically what you see is that in the mutations there's a much less elaborated axonal and dendritic tree that's elaborated in some of the cortical neurons that express SLT-TRAC. And if you look at the microRNA expression of this particular form of microRNA, it mimics to some degree what you see in terms of SLT-TRAC expression itself. So it's a possibility that this actually is a regulator of SLT-TRAC, whether or not SLT-TRAC's involved in Tourette syndrome or not. Interestingly, and this is work that hasn't been published yet, so I thank Matt State for sharing these slides with me. As you can see it in the pyramidal cells, But you can also see it in cells in the cortex that are positive for parvalbumin. So they're present in some of the interneurons. We didn't hear much about the cortical interneurons, but they exist in the cortex as well as in the striatum. And you can see we can see it in the pyramidal cells that are the projection neurons that Dr. von Plessen was talking about as well. Another finding that hasn't been reported yet is that slit track is expressed in these cells that go across the corpus callosum that we were also hearing about from our Norwegian colleague. They're also part of the cortical striatal projections that we were hearing about from Flora, and they're also part of the thalamo-cortical projections or the cortico-thalamic tract that actually has cortical cells that go down to the thalamus. And this is just through techniques that are used where you do retrograde labeling. You inject it into a certain part of the brain and you see where it's expressed in a retrograde labeling fashion. So there have been 3 rare variants of slit track that have been identified. It seems to be regulated in part by mRNA, and it's expressed in cortical projection neurons. So that's all pretty interesting. Here's another piece of interesting data that hasn't been published, and that is that early in development, but not later in development, it's expressed in a group of neurons in the striatum called striosomes. And there's an elaborate theory that I think began probably with Anne Graybiel, where it's the balance between the striosomes and the matrosomes, 2 forms of the medium spiny neurons within the striatum that may be involved in Tourette's. And if we go back to the model, or a version of the model that Flora was presenting, what we can see is that these striosomes are the ones that get dopaminergic innervation. They also get some of the inputs that we were hearing about from Dr. von Plessen with regard to the orbital frontal cortex and the anterior cingulate. And the amygdala and the hippocampus also play a role in here. But all of these projections have slit track in them. All of these black lines have slit track in them in all likelihood, or at least some portion of the cells do. And here's the system that Flora was talking about. And what's just upstream of the tonically active, these are the cholinergic cells, it's these cells that are involved in the striosomes. So the system that Flora was talking about focused mostly on these cells. Here we're looking a little bit upstream of that whole system. So we heard from Flora about the cholinergic cells being reduced in number. We heard about the parvalbumin cells being reduced in number, particularly in the head of the caudate. We also heard about so we don't need to go through that, and we don't need to go through that. So this is not without controversy, and I would just add a caveat before we move on to the next presentation. We haven't found the frameshift mutation in anybody without Tourette's, that is to say that missense mutation. The expression in the brain is of great interest in Tourette's, and rare genetic variations result in decreased brain expression and reduced dendritic arborization. All of that is interesting. Whether or not it's relevant to Tourette's, I think time will tell. This rare variant on the 3' untranslated region has been found in unaffected individuals. 1 or 2 has been found, so that's a question mark. But the group that it was found in was an Ashkenazi Jewish population, and it's interesting that I guess this question I needed to check with Matt actually. I think that these were individuals who were not characterized well with regard to their Tourette's, but what it says there is what I have here. There are also open questions. We found it in 2 people who were not from an Ashkenazi population and who were independent in terms of their how it was derived. These were independent mutations because of the haplotype being different for the 2 individuals. And as I said, they have found a higher rate of this variation in Ashkenazi families, but they were uncharacterized with regard to the Tourette symptoms. I believe that this is the correct statement. So there may not be a single gene responsible for Tourette's. If this is really true, it's probably going to contribute to our development of an animal model of Tourette syndrome. It may help us understand the circuitry that's involved in the neurobiology that underlies the disorder. I would also say that I imagine that as we increase the number of individuals in the International Genetics Consortium will have the numbers that are needed, that have been used in hypertension, have been used in diabetes to identify genes that are common genes but are contributing incrementally to the risk of developing Tourette syndrome. And that's basically what this slide says, is that our technology is advancing very rapidly. Our ability to screen in these association studies is enormous at the moment, and we can look for genetic variation with these SNPs and other forms, the copy number variation that's been talked about fairly effectively at this point in time, as long as we have the samples that are needed to do the studies. So with that, I think I do have some comments, but I'm probably going to skip them, about the epigenetic and risk and protective factors, psychosocial stress, adverse perinatal events Flora spoke about, the panda story, androgen exposure. If people would like to come back to that, either in the question and answer period or at some other point in the Congress, I'd be glad to share with you what we know about that. But if we could switch back to the sort of main slide for the presentation, I'll go on with the neural oscillation story and provide some footnotes. Or I can just run through these things. That will get us there too, I bet you. So we've been doing a lot of work on the immunobiology as well. And there's some cytokine changes, there's some changes in T regulatory cells, and we have an elaborate model of how that all fits with dopamine. If people would like to ask us about it, I'd be glad to share it. So hopefully that will get us to, yes, look at that. This doesn't want to do that. Let's try it here. Okay. Okay, so this is actually more of a footnote to what Flora and Kirsten said, and it's again my venturing into a field. The one before this was immunobiology. This one is actually electrophysiology and magnetoencephalography. So I guess I really feel privileged at Yale to be able to try and learn about different areas of science in the spirit of really trying to help the patients that I serve. And so I'll be sharing with you some of my partial knowledge of this field, and feel free to ask questions and point out any mistakes. Again, I would just emphasize the only reason I've been doing this, in part, apart from genuinely being interested in the science, is to try and make a difference in the lives that we have been, the individuals that we've been working with. And actually, some of the adults that you'll be seeing on some of these slides are people that we have worked with since they were children. And if you've worked with a family for that period of time and their symptoms are still dreadful, you're really willing to turn to almost any option to consider alternative treatments. So that's that quote from Peter Hollenbeck, and I'll be talking mostly about the neurobiology, although I think I've got some stuff in here about the premonitory urges. We've heard about that already. I don't need to tell you about that. This is our, I guess you could say, goal sign, but this is actually the distribution of premonitory urges in a study that we did some years ago of individuals with Tourette syndrome. The darker, the more likely. Interestingly, you can also see asymmetry. Some patients will predominantly have their tics on the right side versus the left side, about 10% on each category. And it's true, if you ask people in a pharmacological study or some other intervention, are the premonitory urges better? Are you feeling the urge as much? If they're better, they're saying, no, I'm not feeling it as much. So I think that there is an intimate link. I think the difficulty is that if you talk to your patients, well, it's a generalized feeling, but sometimes it's a very specific point where it's right here, doctor, and actually that's where the botulinum toxin injections can be very helpful for people with very severe forms of the illness. One of the ways that I try and explain this to family members, and this is based in part on the work of Neil Swerdlow and others, is that probably those urges that they feel are not coming in from outer space. They're probably feelings that arise within the body, that converge on the brain, that the rest of us just filter out. We gate out. And what's the nature of that gate? Why isn't that gate working as well? And that gate working not so well, maybe a whole different mechanism than the ones that we were hearing about before with regard to self-regulation that may be activated in things like habit reversal and so forth. So here's another version of the same circuitry that we were talking about, and the places I'll be talking about, so this is just very interesting to me. This is one of the things about, I sort of have learned neuroanatomy over the years, sort of in bits and pieces, but this was really pretty interesting to me. That there are 3 areas of the cortex at least that are involved in this sort of sensory motor processing. There's the somatosensory area of the brain, where the urges, the feelings are felt. There's the motor cortex that actually implements whatever it is that we're decided to do. But there's another part of the cortex called the supplementary motor cortex. And this is the part of the brain where you sort of experience urges, or I have an urge to do something, but you actually haven't done it yet. And so initially when I got interested in this, I was so fascinated by the fact that there's a somatotopy throughout not only the cortex, so that there are basically parts of the brain that are devoted to this part of the body versus that part of the body. One of the things I found so interesting was that the motor cortical inputs to the striatum and the sensory motor cortex inputs to the striatum converged on the same cells. So that there was a convergence of sensory information and motor information coming into the same cells in the striatum. That I found really interesting. It also turns out that there's the same kind of convergence with regard to the projections from the supplementary motor area as well. It turns out, just to make a long story a little shorter, is that this is the site that we've been using to target with the transcranial magnetic stimulation that Antonio Montavani in Siena actually pioneered this work, and they're using it also to treat individuals with obsessive compulsive disorder. And we've also got some preliminary data that I'll show you in a few minutes that looks suggestive that if you actually alter using RTMS, transcranial magnetic stimulation, the electrical sensitivity in that area, that you can make some difference in the lives of some individuals. The other piece is that here's another point of convergence, and here's another point of convergence in terms of the globus pallidus that we heard about from Flora, that is sort of the output part of the basal ganglia. These are the 2 sites. Here in the internal segment of the globus pallidus and here in the central median nucleus of the thalamus is where we've been using, and other people have been using, actual electrical probes to stimulate to have beneficial effects on some, but not all, of the Tourette patients that have been treated using that technique. So this is just a summary of how all of these things converge, but it's interesting, if you go back and look at that projection, the place where this whole circuit comes back to is the supplementary motor area. So that's the sort of anchor point that I would ask you to think about. I haven't presented some of the things that we heard about earlier, but I'm going to be providing some footnotes to the talk that we heard from Dr. Van Plessen with regard to 2 neuroimaging studies that haven't yet been published that I think you'll find of interest in large measure in part of, at least in one case, in light of her work. So I'm just going to skip through some of the in vivo neuroimaging studies and the post-mortem studies because it's also already well been treated. And we've heard about, these are the different techniques that we use. This is the magnetoencephalography machine. This is actually, there is enough magnetic signal coming from your neurons on your cortex to actually get some sort of magnetic signal from those electrical circuits that are active in the brain. And that's what's actually being measured with this magnetoencephalography. That's what this is all about. Here is our dense array EEG setup and our MRI setup that does both functional and neuro and structural imaging. We've heard about the smaller caudate. One of the things that wasn't mentioned, and I'll just skip to that study, is that it looks like a reduced caudate nucleus volume may be a good trait marker for the structure of the caudate in persons with Tourette's. What do I mean by that? Is that it turns out that there is a relationship between how large your caudate nucleus is and how severe your Tourette syndrome is later in life. And there are 2 areas of the brain that we've looked at that have some value in predicting. So from that same series of patients that were studied that we heard about from the Yale Child Study Center, where we found a lower caudate volume, about 5% difference. It was true both in children and adults. But what we found when we looked at the children was that the smaller their caudate in childhood, the more severe their Tourette's in adulthood. So that there was a relationship between the degree of loss of caudate volume and the severity of their Tourette's in early adulthood. And that's basically shown here in this slide. And this was published a couple of years ago by Michael Block, a resident in psychiatry at Yale. So I'm going to tell you a little bit about two other functional imaging studies before I get into the neural oscillation story. I think it's all related. But basically, there have been several studies now, functional MRI studies, where they've looked to see what parts of the brain are active in Tourette syndrome patients before tics. So in one study done at the NIH, they looked 3 seconds before to 3 seconds afterwards. We've been looking 9 seconds before to 4.5 seconds afterwards. And what you find, and this is the paper from the NIH group, is that before tic onset, you can see these areas of the brain activated. At tic onset, here are the areas of the brain that are activated at the time of tic onset. And one of the areas that, if you look in the axial plane or in the sagittal plane, you can see that there's a pretty large piece of the supplementary motor area that's activated. And there are a number of other areas of the brain that are also activated, and we'll come back to that in a minute. So here's another picture looking at the top of the brain. This is the supplementary motor area before tic onset. At tic onset, you can see a difference there. But it's clearly one of the areas, and one of the things that's so interesting about the SMA is that the neurosurgeons, when they've done, and it turns out that the hippocampus and the SMA are the two major sites for epilepsies. And so the neurosurgeons, when they go and try and take out areas of the brain that may be contributing to epileptic seizures, it's these two areas that they focus the greatest attention on. Interestingly, when the neurosurgeons go in and stimulate in the SMA, the people report, oh, I feel an urge to move. I feel an urge to move. They don't move, but they feel the urge to. So it's as if there is an urge to do something without necessarily performing the action. The need to move in response to pain or the urge to scratch has also been identified as being as part of the same network. So here's the paper that I hope is in press in Brain. I actually haven't seen the final decision by Mark Hallett, but I'm hopeful that it will be there. 16 Tourette patients, 60 healthy individuals. And what we did was we basically had them we had to select very specific patients. These were patients who had a tic in their leg or a tic in their arm, but they didn't move their head. It's been an issue. But we needed them to, it wasn't good enough to suppress it. Here we wanted them to perform the tic in the magnet. So we wanted to, and so we found the area of the motor cortex that was active as they did the tic. And we correlated the activity in that region with areas in the brain that were active back to 9 seconds before and 4.5 seconds in front of after the tic movement itself. And then this may be the most challenging part of the study, is we found normal controls who were willing to mimic the action themselves. And we satisfied ourselves that it was activating the same part of the motor cortex, and we looked to see, with the correlational techniques that Michelle Hampson has developed, what areas of the brain were active before or during or after the tic onset. And basically, these were the different regions of the brain that we looked at. The green is the supplementary motor area. You can see the different areas in the subcortical structures as well. And we looked at all of these. And this is what you see in terms of patterns of activation. And this is what we found, was that the only area where we found a differential form of activity was in the SMA, where before tic onset, which is the 0 point here, so all of those other structures, it was basically the same circuit that got activated when you were making a motor act. The only place that was different was the slope of this line and the pattern of activation that we saw in the left and the right SMA in these patients. So this supports the role of the SMA, and I'll come back to it when I talk about the transcranial magnetic stimulation work that we've been doing. So here's the part that relates most closely to Kirsten's presentation. Here we studied 18 TS patients and 16 controls using an fMRI technique and MEG or EMG. And what we were looking at was this pre-pulse inhibition, a startle response. So typically if you get a puff of air to your throat, and this is what we did, you'll startle. If you get a little puff of air, just before you get the big puff of air, you don't startle as much, for most people. And what people have found in Tourette syndrome is that it doesn't matter whether you get that little puff of air or not, you have the same sort of startle response. There's a loss of the pre-pulse inhibition, and this is thought to be a way of measuring sensory motor gating. And basically, here's an interesting finding. So for those of you that work with Tourette's, we studied, let's back up and just see how many did we study. Okay, there it is. So 11 of the patients had active forms of illness. They were ticking actively. 7 of them were these remitted cases where they had bona fide cases of Tourette's when they were children, but as adults their tics were much better or absent. And then we had normal controls. And here's the finding. These were the active patients, these were the remitted patients, and these were the normal controls. Normally you would expect to see a pre-pulse inhibition. The pre-pulse inhibition was lost in the Tourette patients regardless of whether their symptoms had remitted or not. Some sort of trait marker, some way in which that sensory motor gating issue might still be an issue for them even if their tics are much better. And interestingly, when we made the comparisons with regard to the fMRI images, when you compare pulse to pulse plus pre-pulse, you'd expect to see those areas of the brain that were activated during the way in which you were inhibiting the response to the startle stimuli. And what you can see, it's ventral striatum and medial frontal cortex that are contributing in the normal controls to that difference that we saw. What did we see in the Tourette patients, remitted and unremitted? Absolutely no difference in terms of different areas of activation in the cortex or any other place with regard to the differences in bold activation. So I think this is very supportive of what we just heard in the previous talk. So let's talk about the neural oscillations and ask the question, what do these cells do, the parvalbumin cells? One of the things that Flora didn't mention that I think is a distinguishing characteristic of these cells, and it's not really even shown in this particular slide, is that, and maybe it was in this one, yeah, it's sort of depicted here, is that they form gap junctions between themselves, so that they form sort of unitary groups that can be restructured depending on how they're activated, but they sort of fire together so that there's a way in which they can organize not just the cells that they're in contact with, but other cells to have the same kind of inhibitory input. The other thing that's so interesting about these cells, in my estimation, is that the place where they do their job is on the proximal part of the dendrite. And so they're really having a very powerful input in terms of how they are influencing the signals that are getting into the medium spiny neuron. They're positioned particularly well to have a major inhibitory effect. How are we doing on time, Flora? It's already late? Okay. Well, one of the things that these cells do is regulate some forms of neural oscillation. And this is just a slide showing some of the spiking phenomena that can occur in cells in the basal ganglia as they are in a state where they're not quite yet prepared to do what they're going to be doing. And it turns out that these are the major orchestra leaders. These cells that Flora said are diminished in number, are the ones that are actually regulating the expression of this oscillatory phenomenon within the basal ganglia that's involved in the preparation to do some learned behavior. So what about neural oscillations? Brain circuits, we know about respiration, the sleep-wake cycle are guided by spontaneous oscillatory activity at the level of individual groups of neurons, and these oscillations occur within and between different brain regions in different frequency channels. You've probably heard about gamma, theta activity. It's all different bands of activity. I'll go through this pretty quickly. Of course, the gamma are usually, the frequency is fairly high, and there have been implicated in issues of human cognition, consciousness, and other goal-directed behaviors. You can read here the self-regulatory behaviors that we heard about. And it looks like these circuits play an important role in the emergence and organization of voluntary actions and habits. We've written one review of this article, of this phenomenon, that Flora and Ari Rothenberger from Germany, as well as Paul Calathini, the man who was the first author in the proceedings of the National Academy of Sciences paper that was published with regard to the post-mortem findings that Flora mentioned. We have a couple of hypotheses. I probably should have emphasized the third hypothesis, which is actually the compensatory role that the prefrontal cortex plays in things like habit reversal. But let me just go to, I think if we're really, are we short of time and we're close to the end of the schedule? Because I can just go to the end of this and basically say that there's some evidence for this reduction in high voltage spindles and beta oscillations that may be related to the failure to be able to inhibit. So one of the thoughts is that these high voltage spindles are actually part of what is the mechanism that prevents cells from being aware of the premonitory signals that are getting through for the individuals who have Tourette syndrome. This is a hypothesis. And this may have to do with the relative loss of these fast-spiking GABAergic interneurons in the striatum, leading to an increased sensitivity of those cortical inputs that we were hearing about in terms of the somatosensory cortex feeding into the striatum, and that maybe if you don't have these spindles going on, if you don't have the structural element of the GABAergic interneuron inhibiting in that proximal location those sensory signals, that you may have a higher level of activity and a greater sensitivity to that sensory phenomenon. It turns out that if you look in animal models, there's a form of the Syrian hamster that has a phenomenon very close to what we see in Tourette syndrome, where the tics aren't present at birth, they get worse around the time of adolescence, and then they get better again, and these animals have a loss of these GABAergic interneurons, or a marked decrease in their number. There's some differences that we could talk about, but they may represent the beginnings of a valid animal model for Tourette's. And interestingly, both alpha-2 adrenergic agents like clonidine and guanfacine, as well as D2 blocking agents, reduce these spindles that I was just telling you about that may play some important role with regard to gating of sensory information in the striatum. It's not time to talk about that one. A second one is the thalamocortical dysrhythmia, and this has to do with the emergence of so when we talk about structural imaging, we can look at it over the course of years and decades. Work of Jay Geed, some of the other work that's been done where you look at that, how it changes over time. When we talk about functional neuroimaging, we're talking about seconds. When we're talking about electrical neural oscillatory phenomenon, we're talking about milliseconds. We're talking about the time frame in which these events actually occur. And the two techniques that we have right now, apart from intracellular recordings or recordings from the brain itself, are the magnetoencephalography, where we're looking at the magnetic waves that are being able to be measured on the surface of the cortex, as well as the EEG that we also have data on. And there's a little bit of data that support this. Intraoperative recordings look very similar to what you see in some forms of dystonia and have a dysrhythmia that's present. Turns out that lesions to the areas of the brain that are used now in treating Tourette syndrome with surgery also lead to a change in these forms of dysrhythmia that we're looking at as well. So I'll just present some of the data with regard to the magnetoencephalography. And here we have cases versus controls. And this is basically looking at individuals who have Tourette syndrome who have remitted versus people who have an active form of the illness. And here this is the alpha range, so we see a loss of alpha activity, and that's probably the biggest change. We also see some changes down here in the theta band as well, and when we do ratios, what we see is a big difference between cases and controls. This is something that hasn't yet been published yet. When we look at normal controls, what we see normally during the MEG studies is we see some activation, say, in the occipital cortex, with a very clean band in that area. What we see in the Tourette patients are two different things. Here we see, oftentimes on the surface of the brain, we see unusual patterns of theta activation, that's here in this range, and sometimes in beta activation with regard to the somatosensory cortex that I was telling you about before. You can also see some here in the orbital frontal cortex that Kirsten was talking about. And here's another Tourette case where we see the typical occipital band activity, but also in the somatosensory cortex. So that's another target that we're considering to use in our transcranial magnetic stimulation studies, which so far have been very well tolerated by our patients, I must say. So there's preliminary magnetoencephalography data that support this altered neural oscillatory phenomenon, particularly with regard to theta, the theta band, which is just below the alpha band in terms of where it stands in terms of the activity. I can come back to that later. And let me just do the treatment piece. So for one of our patients who is nearly paralyzed on his left side due to how violent his head snapping tic was, after one of the news reports appeared on the media, he called us and said he would like to have the surgery done. And he was our first case, and we did him 3 years ago. Actually, the greatest experience with DBS, deep brain stimulation, is actually here in Italy, in Milano, and they've done over 25 cases. And I met with them in Norway, and I met with them actually in Stresa last summer, where they summarized the findings that they had. This is Dr. Porta's work. And I think it's fairly promising. Again, although some people have done it in adolescents, the recommendations from the TSA is this only be done in people who are well past that sort of period of time when the tics are typically improving. These are the two sites that show the greatest promise, these midline thalamic nuclei and the globus pallidus pars internus. And this is what it looks like. This is kind of an odd-looking slide. That's where Steve's electrodes are placed, and this is actually a distortion. These are very tiny electrodes, but that's where they're located. I'm not going to show Steve's slide, but basically, over the period of time, he actually had a microthalidotomy effect where for 2 weeks after the electrodes were placed, he had no tics at all, period. They were gone. And you see that sometimes in cases of dystonia as well. In any case, he's gradually gotten better. You'd have to say, if you ask him, he's probably 80 to 90% better. He does a daily tick count, and he's down as low as 12 or 13 ticks a day. On average, though, he's probably around 100. Unfortunately, some of his tics are still very violent in character, and I think he still has the risk of some progression of his illness. The other thing that we're doing, and here we're using this for just very severe cases, and I'm just putting in the protocol now to be able to do a randomized trial for adults and for severe adolescents, is a transcranial magnetic stimulation. And this is basically a technique where you transiently give a big pulse of magnetic energy that alters the electrical activity of the brain in the immediate area underneath it. And here are the summary of the 4 studies that have been done in Tourette's. And this is Antonio Montavani's study here from Italy. And basically 5 patients. This was an open study. We're going to be doing a double-blind study shortly, or a sham control study is what they call it. So Antonio Montavani, this is the group of people in Siena and at Columbia that were involved in the study. And we told you about why we're focusing on the SMA. These are the results from Antonio. And what was most remarkable, this was 5 days of treatment, Monday through Friday, for 2 consecutive weeks. 2 of the patients, one after the first week of treatment, but one after the second week of treatment, stopped having their tics altogether, at least for a 3-month period, according to Antonio. An average of about 66% improvement. An open trial has to be replicated and extended in a sham control trial, but it looks promising. And what I did was, when I read the study, I made an application to the Tourette Syndrome Association, and later we worked together to form an application, a collaboration between Columbia and Yale to do a double-blind study. And here are our first two patients. These are two patients that I know very, very, very well, who I followed for decades. This boy is a boy who was blind in one eye from poking his eye. That's how bad his tics were. And that tic went away. And it's still away, and his last treatment was in January of this year. This boy, unfortunately, after about 6 weeks, had a recurrence of the severity of the symptoms that he had, which is basically a non-stop shouting tic, and he actually responded to a course of ECT that was done at Columbia University. So we're in the midst of continuing this. And the other thing that's interesting is that at least some of the patients during the transcranial magnetic stimulation stop ticking during the 20 to 30 minutes that we actually give the stimulation. So this is the design of our randomized trial. And here are some interesting results, and I'll stop with these two slides. So this is doing magnetoencephalography before and after the treatment. And this is one of the patients. So this is what it looked like before treatment. This spot right here, you can barely see it here, and I'm not even sure you can see it here, but a very intense area of theta band activity in an area of the cortex, not the somatosensory cortex, not the prefrontal cortex, not the striatum, but in a more posterior parietal area, and we can talk about why this may be relevant. But it turns out to be part of the extended associative cortex that's involved in processing of neurosensory information. And this was before treatment, and after treatment, we basically saw the same band, and these bands, these areas of activation, are completely atypical. Rodolfo Llanas, the man at NYU who does the MEG studies for us, has never seen activity like this in all of the control patients that he studied for the last decade. And basically after treatment you see an expansion, but a de-intensification of so there's a reduction in the intensity and the magnitude of the theta band activity in that region. And this, I think, is the second, no, this is, I guess, just the sagittal views of the same patient. So this very clear area of activation that changes after the successful treatment with transcranial magnetic stimulation. So one of the fantasies is that Tourette's is involved, this particular circuit that we've been talking about. As you mature, as you get older, there's probably a lot more prefrontal activation that comes in that's involved in helping the self-regulatory events control themselves better. It may be that if you have severe forms of this illness and a loss of some of these GABAergic interneurons, that you're not really even able to make use of that if that kind of input is not being available, if there aren't the cells there to respond to it. And again, though, with regard to remitted patients, it may be exactly the fact that you've got that prefrontal cortex coming in and helping the child to make adaptations to the urges that they're feeling that's making such a big difference in a majority of the cases. And it may be that the transcranial magnetic stimulation is in some way altering the aberrant neural attractor systems that are at the heart of the Tourette syndrome, not the process that would be involved in the compensation response that you see in terms of prefrontal sites. So here are some of the people that are involved. Actually, Paul has been involved in the transcranial magnetic stimulation work along with Bob King, who's also attending the meeting. Ralph Hoffman has been the fellow who's been using transcranial magnetic stimulation to treat individuals with schizophrenia and auditory hallucinations. Holly Listenby and Antonio Montavani are both now at Columbia and have been very active in helping us with the transcranial magnetic stimulation work. And Carrie Walton and Rodolfo Llanas are the two people who've done the work on the magnetoencephalography. So there's still lots of questions about this, and it may not be that it will prove to be of that much value, but time will tell. And I just wanted to thank our patients and our families, as well as the people who've supported our work. And I'd also like to express special thanks to Flora Vaccarino for organizing this session, and for all of you that have managed to stay through the entire morning and early afternoon. Thank you. This is Matt State, by the way, down here. We can't see him quite, but there he is. He would have been here except for a tragedy in his family.